Hello, everyone, and welcome to the PAPERI Bright Mind Series, held in the recognition of International Childhood Cancer Day, ICCD 2026. This series brings together voices from different disciplines and regions to highlight how research, clinical practice, and health systems can work together to improve outcomes for children with cancer. Today, we are honored to be joined by Dr. Aurora Medina Sanson. Dr. Aurora Medina Sanson is a pediatric oncology specialist from Mexico and the head of the hemato-oncology department at Hospital Infantil de Mexico, Federico Gomez. She is also a level 2 national researcher with Mexico's National System of Researchers. With more than 30 years of experience in the clinical care, research, and academic leadership, Dr. Medina Sanson has made significant contributions to the management of childhood cancers, with a particular focus on leukemia, brain tumors, and retinoblastoma. Her work integrates genomic and translational research to improve treatment protocols and reduce therapy-related toxicity. She completed advanced training at the National Autonomous University of Mexico and pursued a research fellowship at the U.S. National Institute of Health. Dr. Medina Sanson is an active member of leading international oncology societies and serves as a mentor and professor in pediatric oncology and related specialties. We are very grateful to have her perspective as part of ICCD 2026. Dr. Aurora Medina Sanson, thank you very much for joining us today.
Thank you for the invitation. I am really honored with this participation. Thank you.
We have a lot of topics and questions for you to discuss today. And let's start with an important part for clinical leadership and national context. From your experience, how has pediatric oncology care in Mexico evolved over the past 3 decades?
Well, over the 30 years I have served as a pediatric oncologist, I have witnessed the transition of just focusing in basic chemotherapy, radiotherapy, basic surgery, to a more holistic and comprehensive approach to treatment for pediatric cancer patients. Our country has evolved from having only a few specialized units that were concentrated in the main cities of our country to almost having a unit, at least one unit in every state of the republic, what has allowed the patients to have more access, and this has improved the equity to the access for pediatric cancer patients. And this in what I have witnessed is as well is an strategic decentralization of the care. So in the past, we had were overwhelmed with all this receiving patients of all the country, and now this has made a significant change. So that has a very big improvement, and the families have more access geographically. This is an improvement.
This is great. So, what progress are you most proud of in childhood cancer treatment at the national level?
Well, I've been during these 3 decades. I
Yes.
have trained a lot of specialists. So that's one of the a very rewarding part of my work, and I have participated in the creation of national groups, for example, for brain tumors, for retinoblastoma, and I have had participation and projected this internationally too. I have
For training. You
for
mean training,
training, for
which
research.
reflected on patient treatment. you touched this in improvement of patient diagnosis and treatment. You mean this?
Yeah, well, finally, all our work is reflected when you train a resident, you train a leader sometimes that finally will make a change in as a this is like an octopus. This
Yes.
becomes reaches for more than what you even expect many times.
Yeah. Okay. Now let's discuss about an important topic: treatment protocols and the quality of care. So, how important are locally adapted treatment protocols in improving survival and reducing complications?
Well, standardized protocols are already implemented in all Mexico. That's something that it's a governmental implementation. It's not
Ah.
up to us even.
There is a
Although
committee
we
for
have,
this. Excuse me. There
sorry.
is a committee. There is a committee
Oh
that's
yeah,
responsible for developing local, all over the country, a specialized protocol for childhood cancer all over Mexico, right?
yeah. There's a committee, and there are governmental organizations that control the implementation of protocols. They must be reviewed and authorized by committees. Yeah, definitely. Um, but our protocols are mostly based in international protocols. But as you know, the guidelines and the protocols are set in ideal conditions. So implementing the
Ah,
protocol sometimes has a high cost in
yes.
toxicity and deaths. So that is a big part of the our work to adapt these
Ah.
protocols locally and to the necessities and the tolerance of our patients who are different from the patients where in whom were tested these protocols.
Okay, this is the next question. What are the main challenges in implementing evidence-based protocols in resource-constrained settings?
Well, first, you need to have all the drugs that are included in the
Mhm.
protocols, and that sometimes is a limitation because sometimes you might have them in the country, but might not have them in your institution. So that's part of the problems with implementation. Then once you start testing them or implementing them in the clinical setting, you realize that it's not possible because the tolerance of chemotherapy
Yeah,
in let's say unnourished patients is different,
yes, yes.
and just there might be some genetic reasons why they are not metabolizing drugs equally.
Yeah. Now let's move to another important section in your journey: genomics, pharmacogenomics, and precision medicine. I have three questions in this section. How is genomic research influencing the management of pediatric leukemia and solid tumors today?
Well, particularly in leukemia, acute lymphoblastic leukemia, as you know, is the most common cancer in pediatric population. It has a role, and we in our institution we take advantage of this that it has been implemented since decades ago. The
Mhm.
polymorphism of thiopurine S-methyltransferase affect the metabolism of thiopurines, what makes a difference in the tolerance of the pediatric leukemia patients. So the knowledge of their status of this gene, that is an enzyme, is extremely important to reduce toxicity to this drug, the 6-mercaptopurine. So
This
that's
is
one of the main.
Okay,
Mhm.
this is pharmacogenomics, but for genomics and related to diagnosis, do you have implemented or used genomics for diagnosis? For example, leukemia stratification in Mexico at your hospital
Well,
or hospitals in Mexico?
unfortunately, it's not a practice in all centers in Mexico.
Ah,
It is definitely being used. We use it in our hospital, but as you might be aware, this is a third level hospital. So it's not the example of what we see in all Mexico. And definitely, yes, we can already use in our hospital, in our institution, targeted therapy for some solid tumors and leukemias. Immunotherapy is part of this. So yeah, it's part of our tools. However, it's not a reality in Mexico. It's not part of what happens in all the country.
this for
Uh,
diagnosis, you mean?
for diagnosis and for treatment, because you do diagnosis to find
Yeah,
a target um, uh, digamos, let's say targets for treatment,
yeah,
but that's the main goal. Another is to define a particular marker of a tumor and
yeah.
make a more precise diagnosis. That's part of it too. But it's not a reality. We do it in with immunohistochemistry.
Mhm.
Pathologists do that every day. They use biologic markers, but not all the hospitals have even
Uh,
this resource.
you said that you are working at a third level hospital. What do you mean by third level hospital?
Oh, tertiary is a tertiary level
Tertiary, yeah.
tertiary level
Okay, I heard
institution.
it's third
Yeah,
level, so
yeah,
I
yeah,
okay.
yeah.
My next question: How can my question: How can middle income countries responsibly integrate precision medicine into routine care?
Well, it's not that easy. There are priorities.
Yeah, you
So
are right.
if you think about priorities, well, you need first to have what you the basics. So I definitely consider that this is a matter of national health politics, because it's
Yeah,
the how much um, direct the resources you direct to pediatric cancer is even when it is a very sensitive aspect in society, is not the main problem for health, for public health. As you know, pediatric cancer represents only 5% or less of the human cancer. So this is a small proportion. Even when the population, for example, in Mexico, 40% of our
mm,
population is represented by younger of 18. Uh, People under 18 are 40%, represent 40% of our population. But this does not mean the main health problem. So direct resources to pediatric cancer is probably not a priority, because most of the people are in the uh, primary care um, clinics and hospitals of secondary level of attention.
now let's move to another section related to research, translation, and capacity building. My question: What factors are essential to successfully translate research findings into clinical practice?
Well, in a high volume public hospital as ours, the clinical demand is overwhelming. So
Yeah.
finding the time to move from just clinic to research is a constant struggle. So um, uh, it's not easy for most of the clinicians. Um, Research offers us or give us the what is the best treatment, what is the are the risk factors that modify the outcome, what could be a best diagnosis test, but we our daily practice is stated by the how many beds we have,
Oh,
the drug supplies and
yeah.
stuff, radius. So and in the other hand, most of the international research is set in ideal conditions, and sometimes we don't have those. However, we implement through adaptation. So we implement protocols, and
Oh,
we do not our medical clinical research like clinical trials adapt
oh,
are not our main area of research. We
oh,
participate in collaborations, and that's how we incorporate it. We participate with the pharmaceutical industry in their protocols too. But our main research is through data collection, implementation of this data, use of this data to modify our actions, our everyday actions. We do research with samples, as you know. We do pharmacogenomics. We do epidemiological research, and that's how we work with. And it's mostly through collaborations, national, regional, or international too.
so the main focus to strengthen research in low middle income countries through collaboration.
That's what I think, really. What
Is
it
there
has
any
worked for us.
is there
Sorry?
any other approach or method or strategy you can follow other than collaboration?
Yeah, we do our own, but
Ah,
we have a population, let's say 300 to 400 new patients per year. And if you section the different diseases,
ah,
pathologies, well, will be the numbers will always be
small.
small.
Yeah.
So it's not worth it. It's not you are using resources for a small contribution. So
Yes.
definitely collaborations are the answer of research.
Okay. So, what strategies help young clinicians to balance clinical work and research careers?
Well, it's motivation. Motivation is what makes you do research when you're working in clinics. The um, the necessity of answer your questions too, the necessity of implement the what you see, or the new protocols in your population, because then you see that the patients do not respond the same. So pharmacogenetics is a field that open for us to answer why are these difference in outcomes, response. Social research is another field. As you know, there are many social aspects that influence outcomes in our countries, in middle and low income countries. So this is another aspect to for research. Social social components of outcome too.
Okay, so you said that collaboration is very important to improve or to strengthen research in institutions. So, from this point, this is my next question. How have international research networks contributed to advancing pediatric oncology in Latin America in general?
Well, yeah, the population we have in Latin America, there is a Gallup association, and that's a very important part of the of these international groups, twinning and all these strategies to collaborate,
Gallup
because we don't.
south-south or south-north model
Oh,
for
both.
collaboration?
So we collaborate more south north than south. Um, because well, it's even for us it's closer and easier. Well, in the case of Latin America, the diseases are not the same. The conditions are not the same. The proportion of the distribution, let's say, is not the same. For example, in Europe and North America, neuroblastoma is one of the main solid tumors. Is the most frequent extracranial solid tumor, and not in Mexico. We
Really?
have it in probably in this 8th or 10th number. We have 4 cases per year about in our hospital. So,
Brain
but within
tumors?
no neuroblastoma,
Neuroblastoma. Oh, yeah.
neuroblastoma.
Ah, okay.
Um, while retinoblastoma occupies probably the fifth or so position in the list. So as you can see, there are the epidemiology is not the same.
Yeah,
So we have other opportunities to do research,
yeah.
to implement strategies of treatment. As you know, Argentina is a country that has contributed a lot in retinoblastoma, and so it's there. We are different in epidemiology, and that is an opportunity
Yeah.
for learning and implementing, do research, teaching,
And
etc.
cooperation. Yes. Yes, you are right. Now let's move to another important point in pediatric oncology for data, registries, and evidence generation. So, how important are cancer registries and the standardized data system in improving outcomes? You can discuss or give the data registry, sorry, cancer registry at Mexico, for example, how implemented in the last three decades. We
Okay,
hear you.
data is power. Data is the information that gives you a diagnosis of what you have, what is happening, what is right, what is wrong. It's an opportunity to change, to improve, to implement, etc. So in Mexico, this last year was officially implemented the National Registry of Pediatric Cancer. So that was a big step. We have had registries, but this is an officially implemented national registry. Um, it incorporated variables, as you know, social demographic, but also some economic variables, some, of course, clinical. And I, I, um, I am confident that this will make a difference in the future, in the
Sure,
next years and decades,
sure.
because we will have a diagnosis that we don't have at this point.
Yeah. My next question, what gaps still exist in childhood cancer data across the region?
What gives us?
What gaps still exist in childhood cancer data across the region? Gaps in childhood
Oh,
cancer
gaps.
data.
Okay, okay, I see. Um, well, at this point, there's not much data. there's no, in this moment, there are no much data. There are huge difference from region to region, and there are huge differences in registries. If you uh, look at the global registries, if you look at the national registries, for example, in our countries, we have like three different the epidemiology centers. So there is no consistency in our registries, and same happens in the different countries of the region. So you are not reliable. Our registers, these registers are not reliable, because even them within the same country, you can find different registries that have different numbers.
Yes.
So there is no reliability in many of these registries. If you look at global can, if you look at our registries, if you look at local, so there is no consistency. For me, that's the main problem, is there are no reliable registries in many of our countries.
Okay, now let's start another part or discuss about policy and health system perspective. So, from your perspective, what policy priorities are most critical for strengthening pediatric oncology services?
Um, well, we need to target the top. If we just direct our efforts in our institutions, it's not going to be very productive. It needs to be targeted from the those who are the decision makers in the countries. So that's where it must be targeted, because the problem is in the health system. There is a fragmentation of the system in our country. To give it as an example, we have several different um, health systems, subsystems. There's that for the people who don't have any health care. There are those for the workers. There's another system for that who work for the government, for those workers to the government. So there's a fragmentation in the system. So there is no a unified health system, and that's one of the main problems, because when the patient starts in some place, the transition from a first for a clinic, let's say, for a first level clinic, to a tertiary institution, it's a long itinerary, has a long way, and sometimes we receive the diagnosis, the patients in advanced stages. So all this is based on the system. It's depending on many situations related to the health system itself. So there's our system is fragmented. I don't know exactly all the cases for all the region, for all Latin America, but that's the case of Mexico.
Oh, okay. So this answer encouraged me to ask the next question. How can clinicians and researchers better engage with policymakers and health authorities to correct this fragmentation, for example?
Well, it's not that simple. The It's through the councils. Part of it is through the councils. There's a council of cancer, of oncology in general. There are councils of pediatric sub committees of pediatric oncology, and there are pediatric cancer organizations, and it's through this how the request, or that's the bridge to the government. Now, media have been the media have been a big a big element.
Power. Ah,
Yeah, yeah, because it's a pediatric cancer is a very sensitive aspect of the in society, has a high
yes.
impact. So this has have an impact in that has influenced the directions of governmental politics. Actually, now, abandonment is a big problem in countries like ours. So the government has implemented a financial support for all children with cancer to prevent abandonment and reduce all these hidden expenses like transportation, lodging, and some, as you know, some people lose their jobs while in the process of this disease, and the government has covered part of this through a direct financial help for these families. So things have changed. The government has um, directed the eyes to pediatric cancer, and I see this as a big improvement for the whole this holistic uh, let's say approach of treatment, because that now they are covering the social aspects, we are covering the medical part, and with our team we are covering this several aspects, no, psychological and all this.
Yeah, you are right. Now let's move to another important point. As you said, training, you have experience
Mhm.
in training. So, what are the key elements of effective training programs for pediatric oncologists in low middle income countries?
Well, I have trained many generations of fellows and now pediatric oncologists, and I can say that we are moving from just um, let's say not just applying the protocols, but learning other acquiring other skills. Now our residents need to be familiar with data. Our and well, let's say fellows must learn about health systems, must learn about how being leaders of a multidisciplinary team. They must learn how to adapt protocols, how to and let's say advocate for their patients. All these skills must be implemented beside all the clinical training to make create leaders in pediatric oncology that can be head of departments or leaders in their own units.
Perfect. Now let's move to, let me ask another question in this before moving to another point. How can academic institutions support long-term workforce sustainability?
Well, in Mexico, when a doctor, when already a GP, a general practitioner, wants to start a specialty, they need to do an exam to start a specialty. Once they do this, they select pediatrics, internal medicine, surgery, and all this training is covered by the government. If it's 3 years of pediatrics, this is covered. Or they have a scholarship for all their residency, if it's 3, 4, 4 or 5 years, it is covered completely with a scholarship. After they finish their main residency, they can select a specialty, for example, pediatric oncology, pediatric neurology, etc. And this is also covered by the government, and this is recognized by a university. For example, in our hospital, the National University of Medicine certifies the specialty, and this is how it works in Mexico. So all the specialties receive the trainees, the residents, fellows receive a scholarship during all their training. That's the way it works in Mexico. After that, they have to be certified by the councils of the specialty. For example, pediatric oncology, that is included in the oncology council, and that's the way they receive their certifications.
Yeah. So let's move to another question in a very important part, patient-centered care and equity. How can health system reduce disparities in access to childhood cancer care?
Mhm. Well, I think many patients, many families come from remote regions, and that is a an evidence of inequity in for the access of the patients. So creating local or regional networks within a country, this can improve not only the access but the quality of care, because if you not every hospital can have a bone marrow transplantation unit. Not every hospital can have a unit of radiotherapy. But if you regionalize within a country, make a network of that complement the resources, that may improve the quality of care, reduce the difficulties for the patients to migrate to the big cities to get attention. So that's a way Mexico is doing it, through regional nets that complement resources, let's say radiotherapy, pediatric oncology surgeons, bone marrow transplantation units, and different specialists to prevent them to migrate to different to the great of big cities for attention. So
Yes, you are.
that's the way we're doing it, through nets. And interestingly, this is all has grown with the support of the at least in logistics and that of St. Jude's Children's Hospital. So they have helped to direct this
In Mexico?
creating in Mexico, yeah. So we
Yeah,
have regions:
great.
north, northeast, south, southeast, center. So this it has I think it's still evolving, but it's being a great improvement, and a factor that will um, increment, and I can see, because of the results, that some regions of the south, who which used to be the less developed, are increasing their results. So this is a program that I um, proposed probably 2 decades ago, or close to that, to regionalize the treatment. And this is happening now in Mexico. So
Yeah.
I think this is a way to reduce
Yes.
inequity and increase accessibility for the whole country.
Yeah, yes, this is great. Another question in this point, patient-centered care and equity. What role do psychosocial and family-centered services play in treatment success?
Well, we give them the part of chemotherapy, we give them the part of radiotherapy, the treatment of the cancer, but psychologists give them the tools to deal and to cope with the disease through the process. So that's an essential part of treatment. Psychologists must start since day one um, of treatment. Unfortunately, this is not a reality for
Yes.
all the units, all the countries, but it should be like that. We with their help, we improve the attachment to treatment, and the patients and the families have an easier journey with their company.
Now, as we mark International Childhood Cancer Day 2026, what message would you like to share with policymakers,
Mhm.
funders, and the global community?
Um,
Let's start
well,
with policymakers.
policymakers should consider that probably cancer is not the main disease, but it's the main cause of uh, death. Is the main cause of death as a disease in pediatric population. And pediatric population in some countries is almost half of the whole population. In Mexico is 40%. Probably in industrialized countries is less, but it's a huge proportion of the population. So if we consider that uh, one of the main groups of population, that cancer is the main cause of death in the main group of population, you should direct your efforts to treat and and you should invest in the cure of cancer, pediatric
Yes.
cancer.
What about funders? Your message to funders?
Well, to founders, it's the same message. Nobody should die uh, during childhood and adolescence. Nobody should die in this period of life. So consider that cancer is the leader uh, cause of deaths in the pediatric population, and cancer is curable in 70% or more of the cases, but not curable without treatment. Without treatment, 100% of the cases will die. So if we invest in pediatric cancer, we can save millions of years of lives.
I think the same message for the global community.
Right. Right.
Okay, so this is the last question I would like to ask you. What gives you the greatest hope for the future of childhood cancer care?
Well, we are transitioning from basic treatment to personalized medicine, and from very intense and toxic treatments to less toxic and more directed, targeted therapy. So I hope in a near future, all these drugs that now are inaccessible to our patients become of the access of them, of the pediatric patients, of the children, of the adolescents, to help to their cure, because this is a reality we are witnessing, but unfortunately not yet in our countries because of the cost. So I hope, and I am confident that in a near future this will be accessible to everyone.
Hope so. Thank you very much, Dr. Medina Sanson, for sharing your insights and experience with us today. Your reflections highlight the importance of many aspects for childhood cancer in improving outcomes for children with cancer. We are very grateful for your contribution to the PAPERI Bright Mind Series and to the global effort to improve childhood cancer care. This conversation is part of PAPERI Bright Mind Series for International Childhood Cancer Day 2026. Thank you for watching, and we hope these discussions inspire continued collaboration and action for children with cancer worldwide. Thank you so much.
Thank you.